afternoon, everyone. I'm Nicole Dravitt, Account Executive for the Oncology State Society Network and the North Carolina Oncology Association. I want to thank you for joining us this afternoon in today's webinar, Chemotherapy Safe Handling, What You Need to Know. North Carolina Oncology Association is pleased to welcome Dr. Martha Polovich, who will review updates in the requirements and regulations for administration of oral and IV chemotherapy. Before we get started with the program, I just wanted to give you a couple reminders. There is a Q&A text box located at the bottom of your screen where you may ask questions throughout the presentation. Type the question in the box and click the Submit button. We will collect the questions, and Dr. Polovich will answer them during the Q&A portion at the end of the program. This webinar is being recorded and archived. We will provide the link when it becomes available. I also want to mention that registration for the North Carolina Oncology Association and South Carolina Oncology Society Joint Conference on February 19th and 20th, 2016 is now open on the North Carolina website, www.ncoa-northcarolina.com, and we encourage you to complete your free registration online and view the full agenda. Now I'd like to introduce our presenter for today's program, Dr. Martha Polovich, Assistant Professor at the Byrdine F. Lewis School of Nursing and Health Professions at Georgia State University in the Master's and PhD programs. She is a registered nurse with over 40 years of clinical practice, including serving in various roles for ONS related to hazardous drug safe handling. She served on the expert panel for the USP 800 development of the chapter. She is an internationally recognized speaker on handling hazardous drugs, and we're pleased she could speak for us this afternoon. I will now turn the session over to Dr. Polovich.
Good afternoon, everyone. Thank you for joining me, and I'm really pleased to be presenting today on one of my favorite topics, chemotherapy, safe handling, what you need to know. Next. These are the objectives. I hope that by the end of today's session that you'll be a little more familiar with the requirements of the USP 800 Hazardous Drugs Handling in Healthcare Settings chapter. I'll be talking about that quite a bit today. The second objective is to talk about the updates to the COPI standards related to chemotherapy administration safety. And finally, I'd like to be able to discuss some resources for compliance with both the USP Chapter 800 and the COPI standards. Next. So I think it's important that we define hazardous drugs because all of the resources that talk about what precautions need to be implemented when handling hazardous drugs do define which drugs all these precautions are associated with. And so this definition's been around since about 1990. The final criterion was added by the National Institute for Occupational Safety and Health in 2004. And so any drug that exhibits one of these criteria in this list is to be handled as hazardous. Note that the drug does not have to have all of these characteristics in order to be considered hazardous to healthcare workers. So any drug that's a known either human or animal carcinogen should be considered hazardous. Drugs that are toxic to genetic material should also be considered hazardous. Any drug that causes a developmental defect in a fetus exposed in utero or a teratogen should be considered hazardous. And drugs with reproductive toxicity, whether in females or males, should be considered hazardous. And of course, organ toxicity at low doses. And we mean low doses, those that are generally used in practice and not, or in the treatment of patients, and not high doses of drugs or chemicals such as might be administered in a laboratory when evaluating the effects of those agents. So again, as a reminder, any drug that meets one of these criteria should be considered hazardous. In fact, the National Institute for Occupational Safety and Health evaluates all new FDA-approved drugs every other year and compares the known information about those drugs to these criteria to determine whether the drug should be considered hazardous or not. And then they're added to the NIOSH list. So the last NIOSH list was published in 2014, And a review of drugs that have been FDA approved since then has also been recently done, and that list or those updates to the list will be published in 2016. Next slide. So why do we need USP 800 or United States Pharmacopeia Chapter 800, which is specific to the handling of hazardous drugs? Well, there are three main reasons that we're even here today, and I'm assuming that most everyone has at least heard of USP 800. If not, you'll know some more about it after today's discussion. So USP 800 is needed because occupational hazardous drug exposure does result in adverse outcomes in healthcare workers. Of course, we know the adverse outcomes that are potentials in patients who are treated with hazardous drugs, but workers such as pharmacists, nurses, and any other healthcare worker who is in an area where hazardous drugs are handled is at risk. Occupational hazardous drug exposure continues. Usually people don't doubt the fact that these drugs can be hazardous to their health. What most individuals don't recognize is that in their routine work, if they are in areas where hazardous drugs are handled, they're at risk for exposure, and there's some evidence of that. And the third main reason for USP 800 is that organizations really do vary a lot in how they implement hazardous drug safe handling precautions, anywhere from providing all the information, equipment, and personal protective equipment that workers need to not being so good at doing so. And so USP 800 felt that it was necessary to release new regulations, and they are federal regulations, in order to protect healthcare workers. Next slide. So first, I'd like to briefly summarize the adverse health effects that are known about workers being exposed to hazardous drugs in the workplace. Most of the studies have been done in pharmacists, pharmacy personnel, and nurses. There's at least 5 studies published since 2006 that demonstrate chromosomal aberrations as a result of exposure to hazardous drugs such as chemotherapy. One of the more recent studies that was published in 2010 was by Melissa McDermott, who collected data during a study that was conducted by members of NIOSH. And Dr. McDermott found chromosome 5 or 7 abnormalities in both pharmacists and nurses. And the abnormalities in those 2 chromosomes were related to the number of handling events that those pharmacists and nurses undertook related to hazardous drug handling. So as an example, one handling event would be preparation of a dose of drug, or administering 1 dose of a drug, or handling the body fluids of a patient who had received a hazardous drug in the previous 24 to 48 hours. So that's how a handling event was described, and as the number of handling events went up, the occurrence of chromosome 5 or 7 abnormalities increased. And this is consistent, this is significant because chromosome 5 and 7 abnormalities are associated with acute myelogenous leukemia and myelodysplastic syndrome. Sister chromatid exchanges, at least 2 studies have demonstrated those kinds of chromosomal abnormalities in individuals who handled hazardous drugs since 2006. Micronuclei changes were reported in workers in at least 4 studies since 2007. COMET assay, which is an older, more general test for changes in genetic material, there are at least 7 studies that showed changes in workers since 2006. And HPRT mutation, which is it's a substance involved in purine metabolism, and these mutations as a result of exposure to methotrexate and vincristine were demonstrated in at least 2 studies since 2005. Next slide. There's also evidence to support an increased relative risk of the occurrence of cancer in healthcare workers who are exposed to hazardous drugs as compared to healthcare workers who are not exposed to hazardous drugs. So some studies involved pharmacy technicians, and there was a relative risk, an increase of anywhere from 1.1 to 3.6 depending on the study. One study, an old one, in the 80s reported an increased risk of acute leukemia in nurses that was 10 times the risk in the general population. Of course, leukemia is a relatively rare disease, and so 10 times the occurrence seems really dramatic. This was related to workers, nurses in particular, who managed chemotherapy. Overall increased occurrence of cancer in nurses was reported up to 3 times the rate of unexposed nurses in a study by Martin that was published in 2003. Next slide. Adverse reproductive outcomes are also associated with hazardous drug exposure. For instance, infertility, anywhere from 1.4 to 1.5 times the risk in the general population. Lawson published a study in 2012 that reported spontaneous abortion or miscarriage anywhere from 2 to 3 times the risk of the general population among nurses who were handling chemotherapy. The 3 times risk was nulliparous women, and the 2 times risk was in multiparous women. The reason for that is unknown, but the risk of miscarriage was increased in exposed workers as opposed to unexposed workers. Premature labor, premature birth, and learning disabilities in offspring all had an increased odds ratio of occurrence in exposed nurses as opposed to unexposed nurses. And so the reproductive outcomes are quite common in hazardous drug handlers. And that makes intuitive sense. It's biologically plausible because if you think of the fetus as rapidly growing tissues, most of the anti-neoplastic agents are much more likely to affect those types of tissues, the rapidly growing ones. Next slide, please. So the adverse outcomes of exposure are well established. It's also well established that exposure opportunities do occur as a result of being in areas where hazardous drugs are handled. Now, I want to be quick to say that exposure handling does not equal exposure. However, every handling opportunity is an opportunity for exposure. And so we have at least 15 studies that demonstrate a contamination of the external vial surfaces. So most people who handle chemotherapy vials believe that the drug is on the inside of the vial, but it is delivered from the manufacturer with drug on the outside of the vial that's related to the way the vials are filled in the manufacturing process. So every study that's looked at external vial contamination has found it, not on 100% of the vials, but all of the studies did demonstrate that drugs on the outside as well. That has implications for those who handle the vials, even if they're not directly involved in preparing or administering drugs. Unpacking supplies and storing them is an opportunity for worker exposure. More than 100 studies since 1994 have demonstrated workplace surface contamination with hazardous drug residue, meaning that any drug that is leaked or dripped or the contamination is transferred from one surface to another, all those surfaces in pharmacy areas where drugs are handled and in drug administration areas are likely contaminated with the transfer of hazardous drug residue from one item to another. Over 100 studies have demonstrated that. Again, not every surface that was sampled demonstrated contamination, but every study has demonstrated the potential for workplace surface contamination. It's now thought that this is the most likely way that workers are exposed to hazardous drugs in the workplace, because even workers who aren't directly involved in handling hazardous drugs, if they're simply in the area where these drugs are available, have been shown to be exposed to the drugs. And one of the ways that exposure can be demonstrated is by excretion of the drugs and drug metabolites in the urine of healthcare workers. At least 55 studies have been published since 1992 that demonstrate that this occurred. So drug in the urine of a healthcare worker. How did it get there? They were exposed in some manner during their routine work. The drug was metabolized and then excreted in the urine. So there's ample evidence of exposure. All of these different opportunities for exposure in workers who handle hazardous drugs as a routine part of their work. Next slide, please. Several recent studies since 2012 have demonstrated both pharmacists and nurses are exposed in their routine work. So 11 to 17% reported dermal or eye exposure in the previous year. Known exposure, this is not unknown exposure, but they knew that they were exposed either by splashing or dripping or leaks. 4 to 11% reported skin contact in the previous 7 days of the studies that were they asked them about this. 12 to 24% admitted taking home potentially contaminated clothing. And if one is not wearing a gown when handling hazardous drugs, either during the preparation or administration process, then it's likely that drug has been transferred to clothing that then can go home with the worker. A small percentage, 1.4%, reported sharps injuries involving chemotherapy in the previous year, which seems like a lot to me because I hadn't really thought of sharps injury around chemotherapy as being a significant source of exposure. Several studies by Freeze also reported spills related to chemotherapy, and in one of the studies, 12% of those responding reported that they had a chemotherapy spill in the previous 7 days. And most people that I talk to do not really think about spills happening very often and rarely report them. What the studies also showed was that when a spill of a hazardous drug occurred, multiple staff were usually involved in the cleanup of the spill, so more people were exposed in the spill than just the individual who was present when it happened. Freeze also reported that staff who reported spills had hazardous drugs in their urine because during the study, one of the things that they asked was that when they were involved in spill cleanup, that they would submit a urine sample within the next 8 hours. Depending on the timing of the urine was collected based on the metabolism of the drug. But what was really concerning about the study was that the staff who did not report spills also had hazardous drugs in their urine. They did collect urine from other workers who didn't report spills. And there was sometimes drug not involved in the spill found in the urine of individuals. So we have ample evidence of ongoing exposure and recently. Next slide. So in some of my work and in Boiano's study, which was published just this year, Boiano works for the National Institute for Occupational Safety and Health and conducted a couple of studies of nurses and pharmacists in the last few years. The most common reason for healthcare workers not wearing gowns when handling hazardous drugs was that gowns were not provided by their employer. And so if personal protective equipment isn't provided, then the worker cannot use it, and that increases the chance of the individual being exposed. Again, the most common reason for failure to use chemotherapy-tested gloves that have been demonstrated to show protection against permeation by these hazardous agents is the gloves were not provided by their employer. So some employers might be providing boxes of gloves, but they may not be appropriate to the hazard because chemical protective gloves certainly are of a different grade than those that are meant to protect against blood and body fluids or just for general food services and other cleaning type activities. And Boiano asked about the use of closed system transfer devices. These are engineering controls that minimize leaks when drugs are transferred from one container to another. In Boiano's studies, only 25% of nurses in his study used closed system transfer devices, and a little bit less than half of the pharmacists used the CSTDs. This is important because one of the new recommendations or one of the new regulations from USP 800 will require the use of CSTDs during drug administration. Next slide. So I'm going to, we'll talk now about USP 800 and what the recommendations are from USP 800. Next slide. So the U.S. Pharmacopeial Convention, or USP, is a scientific nonprofit organization that sets standards related to drug and food and dietary supplements. You've probably seen USP printed on an IV bag or other IV supplies saying that they meet particular standards. So their standards are related to the identifying products, the strength of products, the quality of products, the purity of products, and also food ingredients and dietary supplements. Those USP standards are enforceable in the United States by the Food and Drug Administration. And these standards are also used in more than 140 countries across the world. So I think it's important to recognize that in between 2011 and 2012, there were 4 serious incidents of contaminated pharmacy-prepared sterile products resulting in harm to more than 200 patients. And this, of course, was related to contamination of several thousand, 17,000 doses of a drug that was prepared by a compounding pharmacy and subsequently distributed for injection into patients. And about 704 people were affected directly, and 46 people died as a result of this. And as a result of those unfortunate incidents, most of the pharmacy, state boards of pharmacy in the U.S. have adopted the USP standards officially and will be enforcing the USP 797, which is related to sterile compounding, and it's anticipated they will also be enforcing USP 800, which is a chapter specific to hazardous drug handling in healthcare settings. So of course we're very much aware that many of the hazardous drugs, chemotherapy that are administered to patients and are sterile products because they're administered intravenously. And the previous standards, USP 700, had a section related to hazardous drugs, which was quite basic and did not contain a lot of detail. And that's the reason that USP 800 was proposed and approved, because it addresses in detail how to protect not just the patient receiving hazardous drugs, but also the healthcare worker. So I think it's important to recognize that the USP is enforceable by FDA and also directly by the North Carolina State Board of Pharmacy. It's one of the state boards of pharmacy that specifically points to USP, and they have specific language regarding compliance in their recently updated rules, as most recent as December of 2015. Next. So everyone's asking who and what facilities will be impacted by USP 800 related to hazardous drug safe handling, and the language in the standards states it's applicable to all healthcare personnel who handle hazardous drug preparations and all entities which store, prepare, transport, or administer hazardous drugs. So the USP 797 did have a small volume exception for hazardous drugs, meaning that the entire chapter did not need to be implemented if the entity was a small volume producer of hazardous drugs. but the USP 800 doesn't allow for any exceptions based on the volume of drug handled, the category of personnel preparing or administering the drugs, or the type of facility. And so some organizations opted out, so to speak, of USP 797, saying that it wasn't applicable to them either because they didn't have pharmacists, or they didn't have a pharmacy, they had a mixing room, or they only prepared a small volume of drugs. And those exceptions are not allowed for in USP 800. Next chapter, next slide. So here's an overview of the provisions of USP 800. So the chapter is organized into 18 main sections and begins with the first standard that states any organization that has hazardous drugs at all needs to maintain a list of all hazardous drugs in the facility. And it specifically states that if there's a drug on the NIOSH list, the most recent NIOSH list, this one being the 2014 list, if it's handled in the facility, then it needs to be on the list of hazardous drugs. So this is, if you're not having chemotherapy or other hazardous drugs in your facility, then you're not required to be compliant with USP 800. If you only have specific drugs in the organization then that are on the list, then that's all that's applicable. Most organizations that handle chemotherapy, of course, will have a large number of these agents, but these some organizations only have hormones that are on the list of hazardous drugs, and so that would be the only type of agent that would have to be on the list of hazardous drugs in that organization. So that's the first provision. The list has to include all drugs in the NIOSH list, and the list in the organization needs to be updated every couple of years. Well, it's updated by NIOSH every 2 years, but the organization should review the list every 12 months to make sure that it's inclusive of all the hazardous drugs on site. And so what's important is that drugs on the NIOSH list meet at least one of those criteria for being considered hazardous. This next provision is that each entity that has hazardous drugs designates someone to oversee compliance with the standards in the chapter, and that individual needs to be qualified in order to do that. The next provision is related to facilities and engineering controls, and that includes separate storage areas for hazardous and non-hazardous drugs, that there's a primary engineering control that's available and used for the preparation of both sterile hazardous drugs and non-sterile hazardous drugs, that the engineering controls include negative pressure in the room where the drugs are prepared, so that there's no positive pressure pushing hazardous drugs out into the environment. There's a requirement for external venting of the primary engineering controls, in other words, no venting back into the workspace because of the potential for worker exposure. And one of the, I think that's going to be a problematic provision to be implemented is that drug administration, hazardous drug administration is going to be, there's going to be a requirement for closed system transfer devices. So in other words, nurses who administer hazardous drugs will have to be using closed system transfer devices for drug administration. It's a recommendation for drug preparation, but it's going to be a must or a requirement for drug administration. Next slide. The continuing provisions include a quality control program for the environment, the safety of the environment, a hazard communication program, which is an OSHA requirement that whenever there are chemicals that are hazardous to workers in the workspace, that the organization or entity has to have communication to the employees about the potential hazards and how they can protect themselves against those hazards. There's a requirement for appropriate labeling, packaging, transport, and disposal of all hazardous drugs, that there's a requirement for personnel training, that there's a spill control plan, that the entity has decontamination protocols, not just for the cleanup of spills, but for regular maintenance of the sanitation and decontamination of the environment where these drugs are handled. There's a requirement for personal protective equipment that's quite specific, and there's also a requirement for medical surveillance of personnel, and this is another one of the areas that many individuals are finding challenging to implement. Next slide, please. So I think it's important to recognize that USP 800 will have an impact on nurses who are handling hazardous drugs. In my experience, even though I am a nurse, nurses that I talk to are not aware of USP at all, let alone USP 800, the new regulations that were just announced in November of this year, and that will go into effect or be published as of February 1st, 2016. And so I think it is an important part of implementing the standards that all the nurses are educated about what the requirements are for USP 800. USP has never before had standards that overlap with drug administration. They've always been focused on drug preparation, drug compounding. But because nurses are intimately involved in the administration of hazardous drugs, they set standards to address the safety involved in drug administration. And so the important aspects involve the required use of closed systems when the dosage form allows. And I think that's important language because closed systems are not available for all routes of administration. So for instance, there's no real safe way to administer an oral agent. There's no closed system, at least for that, unless the drug is being administered via a tube, and then there might be a way to adapt a closed system to do that in a safer way. Closed systems are available mostly for injectable drugs, whether that's IV or intramuscular or subcutaneous injection. The next provision is the use of protective techniques when spiking or priming IV tubing. USP is quite clear, as are other recommendations from pharmacy organizations and nursing organizations, that spiking into a container that has a hazardous drug in it is an opportunity for exposure, and this should not be done. This should be done with plain fluid before the drug is added to the container. It's also clear about the use of chemotherapy-tested personal protective equipment and the use of procedures that will minimize manipulating hazardous drugs, such as crushing of tablets or any other preparation that would have to be done prior to administration. All of those activities should be done in a manner that minimizes the exposure to the individual who's handling the drug. So it's important to recognize the need for updating procedures and policies, and also for updating the routines that nurses are used to implementing to administer IV and other hazardous drugs. So it's really important to involve nurses in the process because there's a need for collaboration and education. If a closed system transfer device is going to be required for drug administration, then those who administer the drugs need to be involved in the selection and testing of those devices that will be used in the administration setting. And one also has to recognize that if CSTDs have not been used in the setting before, that the time to provide the guidance, training, and implementation of these devices is really quite long. So you cannot do that in a month or so. So there will be requirements for some lead-in time in order to make this a smooth transition in order to meet compliance. Next slide, please. So for those of you who are not familiar with CSTDs or closed system transfer devices, this is the definition from NIOSH, which was published in 2004. It's a device that mechanically prohibits the transfer of the environmental contaminants into the system and also the escape of the hazardous drug or its vapor outside the system. So at the time of the NIOSH 2004 publication that defined CSTDs, there was only one product on the market. Now, many years later, I think the first CSTD came on the market in the U.S. in 1999. Now there are 5 products currently available in the United States. And there is a new testing standard that was developed by NIOSH that will be published sometime in 2016 for evaluation of these products to demonstrate how well they do what they claim to do, that is minimizing the escape of the hazardous drug outside of the system. So that new testing method will be available sometime in the next few months. Next slide, please. So CSTDs have been controversial because a lot of people believe that if they follow all the precautions and are careful, whatever that means, in the handling of their hazardous drugs, that a CSTD is unnecessary for worker protection. However, since 1999, when the first CSTD became commercially available, many studies have demonstrated that CSTDs will decrease hazardous drug contamination in both compounding and drug administration. Specifically, decreased amount of drug found in the urine of healthcare workers when CSTDs were used as compared to not being used, and also the decrease in surface wipe or surface contamination when CSTDs are used as compared to when they're not used. So there's multiple studies in the literature that demonstrate the effectiveness in CSTDs of not totally preventing exposure, but significantly reducing exposure. So there are some sources of contamination that CSTDs cannot address. So external vial contamination, CSTDs won't do anything about that. Chemotherapy spills, CSTDs can't prevent those sources of exposure, or handling patient waste. But CSTDs are the only engineering control, which is the highest level of protection, that's available to those who administer hazardous drugs. Those who compound or prepare hazardous drugs have biological safety cabinets and other containment devices, but a CSTD is the only engineering control that provides protection for those who administer drugs. So one of the drawbacks is that no study has ever evaluated the cost benefit of using CSTDs, and so some see that as a limitation to the devices. Next slide. So I'm going to briefly review what the recommendations or the requirements for personal protective equipment when handling hazardous drugs include, and these have been harmonized between all the organizations that make recommendations for hazardous drug handling: the American Society of Health System Pharmacists, NIOSH, OSHA, and Oncology Nursing Society, and these are also the same recommendations that USP 800 is making at this time. So gloves used for handling hazardous drugs should be tested against hazardous drugs, and there is a testing standard for that from the ASTM that measures permeation of specific hazardous drugs through glove material, and in order to be designated as a chemotherapy tested glove, the glove has to protect against permeation for a minimum of 30 minutes. There's also recommendations for double gloving when handling hazardous drugs, and I'll address that in a minute. Drugs should be powder-free. They can be made of multiple materials. The material is not as important as having been tested against permeation with hazardous drugs. However, there are some drawbacks to using latex gloves, and so there are other materials that are less likely to cause allergies or reactions in healthcare workers. So 2-pair tested with hazardous tested against permeation with hazardous drugs, and gloves that have passed the test are labeled as chemotherapy tested gloves and should list the ASTM standard on the box. Gowns should also be tested with hazardous drugs. Unfortunately, there's not a standard for testing against hazardous drugs. What some of the gown manufacturers have done is use the same drugs that are used for the ASTM glove testing to test their gown materials. So they will be labeled as having been tested with hazardous drugs. There are many studies that have evaluated gown materials against permeation by chemicals. Certainly, chemical protection is different in a gown than the kind of gown that's used for the protection against blood and body fluids. The other requirements for gowns is that they have a cuff in order to protect the arms or the wrist of the worker, and the gown cuff should be covered with the glove cuff. And the gown should close in the back in order to fully protect the front of the worker, which is the area that is most likely to be contaminated by hazardous drugs. Next slide, please. So there's a recommendation for double gloving. Next slide, please. There's a recommendation for double gloving, and even though glove materials have been tested against permeation by chemotherapy, some drugs, these two in particular, carmustine and thiotepa, which are not all that commonly used, have a very short permeation time, and there are very few gloves that are protective against these drugs for more than a few minutes. Anywhere from 3 to 10 minutes, either one of these drugs can permeate through the typical glove materials. There are only two, I believe, gloves, chemotherapy tested gloves on the market that are recommended for use with these two drugs. If you're not using these drugs in your setting, then almost any chemo-tested glove will be appropriate for that. But certainly double gloving is recommended for that extra layer of protection for certain drugs that are more likely to permeate. The main reason for double gloving as a recommendation is to prevent the transfer of contamination from the outer gloves either to the hands or other surfaces during handling activities. So gloves, 2 layers of gloves protect the worker so that when the worker is finished with the handling activity, he or she carefully removes the outer glove, turning it inside out as it's being removed from the hands, and then the hands are still protected by the inner glove. Then the gown is removed and the hands are still protected after having finished all the potentially contaminated materials, and then the last thing to come off are the inner gloves, which have protected the hands. So it's important, it's a work practice that prevents the worker from transferring contamination from the outside of gloves to their skin. And at least 5 studies have demonstrated that the outer glove is very frequently contaminated during almost any handling activity, and that chemotherapy gloves that are used for handling chemotherapy should always be considered contaminated, even if there's no obvious drip or leak. Next slide, please. Some other types of personal protective equipment are recommended depending on the particular task related to the hazardous drugs. Eye protection is required when splashing is possible. Of course, it's not always necessary. Splashing is not always likely to occur, but intracavitary administration via a catheter, say into the bladder or the peritoneal cavity, such as for ovarian cancer or bladder cancer, these connections that are used with these types of administrations weren't designed to prevent leaking, and there's always the possibility. And so one would wear eye protection doing those types of tasks. And then a respirator is required when there's the potential for aerosols or when spills are being cleaned up. So respirators might be necessary when drugs are aerosolized. So if you're administering an aerosolized drug, that's of course an opportunity for inhalation, and a respirator should be worn. But also aerosols can be released or generated by squirting air out of a syringe, for example. and that would, if one shouldn't do that with a hazardous drug, but if one had to do that, then respiratory protection would be recommended. So it's important to note that surgical masks do not provide respiratory protection. They may not even provide splash protection. But safety data sheets describe the appropriate type of respiratory protection based on the drug in question. Next slide, please. So one of the provisions in USP 800 that is causing some individuals some dismay, I guess, would be the requirement for medical surveillance. So hazardous drug handlers may be at risk for exposure based on their activities, and a recommendation that's been around a really long time, OSHA made the same recommendation in 1986 with their first initial recommendations for hazardous drug safety for medical surveillance of workers who are potentially exposed to hazardous drugs. So medical surveillance involves collecting and interpreting health data about exposed workers. So the purpose of medical surveillance is to identify biological effects of exposure early in order to interrupt the sources of exposure, to detect any early changes in the health status of workers who are potentially exposed, to correct other prevention failures. So for instance, if you identify that exposure occurred because of failure of protective equipment, then you can implement the strategies to prevent that from happening in the future. And the goal would be to prevent adverse outcomes in other workers, even if they couldn't be prevented in this particular worker in which the health change occurred. So this is a source of anxiety because many organizations think that medical surveillance is going to add significant cost to the monitoring of workers. And this is one of the requirements of USP 800 that has to be implemented. Next slide, please. So USP 800, these are the requirements, or these are the provisions for medical surveillance. The first is that the entity has an organized approach to identifying potentially exposed workers. So an organization should be able to identify all those employees who are potentially exposed based on their work duties. That they would provide surveillance that's appropriate to the exposure, that they would perform pre-placement health assessment for workers, and this is to identify if they have any health problems prior to beginning handling of hazardous drugs to determine whether they should indeed even be involved in this kind of work or if they're at increased risk for whatever reason, health reason. That they provide periodic and routine health appraisal, that they are able to track exposure, both routine tracking and acute exposure, such as what happened around a spill. That there is someone who will be monitoring the data of the health related to health changes, and that there's a follow-up plan for workers related to health changes, and that when workers leave duties where they are handling hazardous drugs, that there be an exit examination to evaluate the health. So something such as documenting the exposure history, something that we have difficulty following now because most people don't do these kinds of activities. So I think what's important to realize about the medical surveillance program is that many small entities aren't able to provide these kinds of services because they don't have an employee health service. However, these kinds of services are available by referral to occupational health physicians in the community. And so an organization doesn't have to provide all of these services, but they do have to have a plan in place that identifies what workers are supposed to do related to monitoring of health and, of course, for follow-up after acute exposure. Next slide. So if one is acutely exposed, such as has a spill on their person or they're involved in a cleanup of a spill, then there should be a plan in place about follow-up for that type of exposure. If it's an inhalation exposure, they should have a plan for that. If it's skin exposure, they should have a plan for that. If it's ingestion or injection, there should be a plan in place. There should be an assessment of the extent of exposure of the worker. There should be a physical examination relative to the type of exposure. There should be a treatment plan and protocol for what needs to be evaluated in the employee. And then there needs to be some follow-up about what controls were in use at the time of the exposure. And then there needs to be an action plan in place to prevent additional exposure, so an evaluation of the adverse event. And then evaluation of the effectiveness of the plan. So organizations can choose to refer their employees to an occupational health physician or also their personal care physician for routine surveillance, but they still have to have a plan in place for managing acute exposure. So employees need to know what to do in the event of a known exposure such as following a spill. Next slide. So I'm going to briefly discuss the ASCO-ONS chemotherapy safety standards and how they relate to COPE recertification. And the main reason for discussing this is that the ASCO-ONS chemotherapy safety standards have recently been revised and are currently out for public comment. So I would encourage all of you, whether you're a nurse or a physician or practice administrator, because these will be applicable to setting standards in your organization, that you review the updated standards and please submit comments in the public comment period. I believe it's through January 16th. I may be incorrect about that. Next slide, please. So ASCO-ONS chemotherapy safety standards have been around since 2009, and they're related to patient safety. And they were developed to be applicable to diverse practice settings. Hopefully they're clinically intuitive and can be related to safety. Realistic to achieve, we hope that's the case. Valid and evidence-based. This newest iteration of standards that are out for public comment now the revisions began with a structured literature review, and so they are evidence-based. Hopefully they will reliably impact patient safety related to chemotherapy administration, that they can be measurable so that one can demonstrate compliance with the standards, and that they can be acted upon. Next slide, please. So in the 2015 and 2016 revisions, they'll be published sometime in 2016, some of what's new in the standards is that all healthcare settings where chemotherapy is administered will the standards will be applicable in all healthcare settings. The initial 2009 standards addressed outpatient chemotherapy. 2011 standards addressed added inpatient chemotherapy. The 2013 updates added oral chemotherapy to the standards. And in this iteration, we're also addressing the use of chemotherapy in pediatric patients. There's an expanded glossary in the standards in order to use economy of words, so to speak, in wording of the standards themselves. Many descriptions in the standards were relegated to the glossary, so there's an explanation of what is meant by particular words used in the standards. And this one involved a reorganization of the standards, which we hope will be a little more intuitive to those who are trying to implement standards in their setting. Next slide, please. So I have included, the draft standards are open for public comment until January 13th. Sorry, it's the 13th. And there are links to both the standards and the public comment section. So you'll have to access the standards to review them and then access the comments, the website survey for the comments. Next slide, please. So in the original standards, next slide please. This was the way that the standards were organized in the domains, from beginning reviewing information, treatment planning, ordering, prescribing, and then ending with response and toxicity monitoring. Next slide. The updates have reorganized standards, hopefully to be a little bit easier to address and implement. The first domain would be creating a safe environment, and most of this was related to policies, including staffing, training, and general policies about safety. The second domain, treatment planning, patient consent, and education. So all of the standards relating to those particular aspects of chemotherapy treatment. The third domain, ordering, preparing, dispensing, and administering chemotherapy, so the specifics on how to do that in the safest way possible. And then the last domain, monitoring after chemotherapy is given, including adherence to chemotherapy, safe for patients who are on oral treatment, managing toxicity, and managing the complications of treatment. Next slide. So one of the things that provides a source of anxiety for people has to do with chemotherapy consent. And the standards do not require a separate written or signed consent by the patient for administering chemotherapy, whether that is intravenous or oral. The standard does address the need to provide information so that the patient can understand the treatment, and there needs to be a consistent way in your practice for how that consent is documented. Notice that we added assent, since this is also applicable to pediatric patients, so depending on the population, whether adult or pediatric population, you have to have a consistent process in your organization or your practice setting for how consent is documented. There's some specifics in the standards about information that needs to be provided to patients so that they can be adequately informed in order to give their consent. Next slide. One of these standards that's related to the safety with oral chemotherapy is related to dose adjustments and changes to orders that occur when the patient is at home and not in the setting such as they might be for IV chemotherapy. And so this is a standard that I think I wanted to call out because I think it's really important. New orders or changes to orders can be problematic related to safety. So if the oral chemotherapy regimen has a dose adjustment that is communicated directly to the patient by the provider, that there's a requirement in the standard that those changes are documented in the medical records so that everyone is aware of the changes in the treatment plan for the patient who might not be seen in the office when the change is made. Next slide. So there's another one addressing when you are prescribing oral chemotherapy. I think one of the challenges we all have is that prescribing physicians have limited control over dispensing pharmacies. So you can write a prescription, but you can't really control the safety of the dispensing pharmacy. But safety is impacted by the way the prescription is written, and so there are very clear steps in the standard that address all the information that needs to be included in the prescription, whether this is an oral agent or an IV agent. And often an organization has a pre-printed order or a standardized order form for IV chemotherapy. That's not always the case with oral agents, and the standards don't prescribe a pre-printed order for oral agents. Note that the number of refills needs to be indicated in prescriptions for oral chemotherapy, and that 0 may be the default value for refills, so that patients might not be taking chemotherapy longer than anticipated. Next slide. Because the standards cannot address what the dispensing pharmacies do, then it's a problem sometimes. But if your setting specifically has its own pharmacy and does dispense oral chemotherapy, then there are specific elements that should be included on the label for those oral agents. And I won't read them all here. They're listed in the standards. But again, if you do dispense oral chemotherapy from your setting, then these standards will have to be followed. as far as labeling. Next slide. Oh, I guess we're to the references. So I apologize for going on long, but I will be available for questions, anything specific to either the safe handling or the ONS standards, ASCO ONS standards.
Thank you so much, Dr. Polovich. We do have some questions for you, so
Okay.
I will read them. The first one is, will it be mandatory to change gowns after each use, one time only after each use, one time only after use?
Okay, so the recommendations for gowns is that the gown should be worn during all handling activities. In an outpatient setting where, for instance, the individual who is administering the drugs, the nurse, is going from one patient to another, continuously handling chemotherapy, there's no need to change the gown in between patients because it's not an infection control requirement. It's a protection for the healthcare workers to protect their clothing from exposure. So when we say a gown should be single use, it means that it's worn during the handling activities and then it's discarded at the end of the handling activities. But once the gown comes off, then it needs to be discarded. Now, unfortunately, in an inpatient setting, it is likely to be go in the room wearing the gown and remove the gown because you're leaving the area where the hazardous drugs are being handled. And so it is, in an inpatient setting, it is one single use might be one patient.
Okay, and another question is, what are the consequences if we don't comply with the new regulations or standards?
Okay, so USP 800 is the first federal regulation related to mandating that workers such as nurses and pharmacists and other healthcare workers in settings where hazardous drugs are handled will be provided the equipment that will make their environment safer. So again, federal regulation. It can be enforced by the Food and Drug Administration, and most of the pharmacy boards in the U.S., state boards of pharmacy in the U.S., have agreed to be on board to audit for compliance with USP 800. The Joint Commission indicates that they are potentially going to audit for compliance with USP 800. So what comes into question is we really don't know who's going to be auditing for compliance. If there's no pharmacist in your setting, say nurses are responsible for drug preparation, then the State Board of Pharmacy may not be involved in the audit for compliance. So it's really unclear who is going to be auditing for compliance. But I think it's important to recognize that there are federal regulations and that they can be enforced. What the penalty will be for noncompliance isn't clear. So the standard USP 800 will be published February 1st, 2016, and the implementation, meaning the date when you have to meet compliance, will be in July 1st of 2018. So there's a 2.5 years almost of implementation.
All right, thank you. And we have one last question before we wrap up. Is how is surveillance, in parentheses, lab handled? What do we need to know?
So what's in the USP 800 related to medical surveillance is there should be baseline labs for general health of employees who will be handling hazardous drugs. There is no requirement for annual laboratory monitoring. There's a recommendation that that healthcare workers will have a health appraisal, which can include use of a questionnaire about health changes, and that if an individual has changes in their health, then the changes will point to what particular lab monitoring might be recommended for that individual. So there's no requirement for annual labs. It should be based on the findings in individuals.
Alrighty, well, that's all the questions we have for today. So I want to thank you again for presenting. It certainly was, I hope everybody found it beneficial. I know I did. Thank you all for tuning in today, and I hope everybody has a great weekend and happy holidays.
Thanks.
Thank you.